Welcome everybody. I think we'll make a start. We've got our guests arrived. So welcome to this latest in our webinar series around optimising timely discharge. This is the first of the series with a number of others organised over the next few weeks. So please do look out for those as they come out. So today we're going to be discussing the role of SDEC and emergency departments in managing demand at the front door. So the way we're going to run this is an open floor discussion and welcome questions from everybody who's joined today. Please do put your hands up or pop your question in the chat. I'll keep an eye on those. We'll be posting those directly to our guests who will introduce themselves in a moment. In between the questions, please stay on mute if you can, just to avoid any kind of background noise. And we are recording this session and we'll make it available in the next 48 hours or so via our YouTube channel. So I'm going to hand over to our guests just to introduce themselves in a minute. Dan, do you want to introduce yourself?
Morning everyone, I'm Dan Boden, emergency medicine consultant. I do my clinical work at ULHT at Lincoln, and I'm a clinical associate for ECIST.
Thanks Dan. And then Steve?
Hi, I'm Steve Barden. I'm the lead consultant for acute medicine and same day emergency care in University Hospital Sussex East, which is Brighton and Haywards Heath. I'm also ED trained by background, and I'm an ECIST clinical associate.
Thanks, Steve. So we've also got Crystal with us today, who's looking after us in the background, making sure all the technology works. And as you just posted in the chat now, any questions for our two guests around how we manage demand at the front door, please put those in the chat, or we can put your hands up and we'll refer to you. There's no presentation. This is just an open floor discussion. So I'm going to sort of kick things off, and I think this is more towards well, I don't want to pigeonhole, but Dan, I don't know if you want to pick this one up in particular. So we've always emphasised the importance of avoiding unsafe discharges. So how do you balance that with the need to avoid unnecessary admissions through ED?
Yeah, it's a really important question, Nick. And I think for quite a long time, undergraduate training and as junior doctors, we've been taught that the hospitals are a safer setting for our patients. And it's undoubtedly true that certain groups of patients are better managed in a hospital bed. So if you've got, deranged physiology and you're at imminent risk of deterioration, or if your treatment has to be delivered in a hospital bed, or if you're just not going to be able to function with, outside of a hospital setting, then that's pretty much without debate. In that way you are currently, you require an inpatient bed, and we should recognise that. And then our role is to try and optimise their care while they're in hospital and get them discharged in as timely a manner as we can. The big area of kind of focus is, and the bit that we probably haven't yet evidenced as well as we could, and the bit that we probably haven't communicated as well as we could, is the risk of harm of admitting patients to a hospital bed. And some of that's pretty well published around deconditioning, hospital-acquired infection, hospital-acquired functional decline, some of the changes in sort of dementia, short-term memory, mental health of requiring admission. But there's four groups of patients, I guess, who are really affected and potentially come to harm by admissions that maybe could be avoided. So you've got the patient themselves that we've talked about with the risk of admitting themselves. Number two, you've got the patient on a trolley in the emergency department who's waiting a bed, and they're waiting a bed because other beds are potentially utilised by patients who don't need to be in an acute trust bed. And there's some published evidence of harm from the EMJ in the last week from Cliff Mann and Chris Moulton around that harm. And that's pretty, 1 in 82 patients who are in ED between 6 and 8 hours will die that otherwise would not have died. So that is a pretty significant risk while waiting for a hospital bed. And the other two groups of patients who come to harm are those in an ambulance who are waiting to come into ED. And probably the biggest risk of all is the patients in the community who don't get an ambulance because of the ambulance crews outside of EDs. So there's huge risk of admitting. And the big question is, what can we do differently to reduce avoidable admissions? And for me, there's three kind of tenets to that. Number one is let's use and socialise criteria to admit. That we've pushed pretty hard on that the past few weeks and months. That's a really good, useful tool to think about: are we admitting the right patient appropriately? Number 2 is utilise our resources available, so same-day emergency care, hot clinics, specialty clinics, etc. And number 3, and the bit that we do badly, and I was on call last night and I was astonished that we just don't ask our patients what they want. And actually, if you ask the patient, do you want to be at home or do you want to be admitted? The vast majority want to be at home. And so we've got to really push that a bit more of what do our patients want and you know, and how can we facilitate their wishes rather than what we think is right. So pretty long-winded answer, but it's what can we do to reduce admissions, but balancing that risk. Oh, Nick, you're on mute, I think.
Schoolboy error. Steve, any thoughts on that?
Yeah, I mean, I would just like, you know, if I describe kind of my practice in kind of working through this is, yeah, absolutely. There is a cohort of patients where it's a no-brainer need to be admitted. And that's basically the criteria to admit tool. And you can get that information from primary care, and quite often you know that the patients, you know, lying on the floor, can't stand up. Well, clearly they're coming into hospital today, they're delirious or whatever. So that's one group. But the other group where the confidence has to grow really is, you know, the process that acute physicians do in terms of, you know, what is the predictable, what is the condition the patient's in, and what is the predictable rate of decline in terms of, is there a predictable rate of decline? And if so, is that expected to happen within the next 12 hours to 24 hours? If so, you probably need to bring them in. And that's where the kind of vascular, you know, you've got well people, but they've just had an acute coronary event and they've got to come in, but they look well. So that's fundamentally vascular. Everyone else, it should, the question I'd also bring into that is how far they live from hospital and who's at home with them. So, you know, unfortunately, the ambulance services now at this critical time might be the rate limiting step of getting back to hospital. But if you only live around the corner and you've got a car and you've got somebody sensible at home with you, getting back to hospital is going to be a pretty easy thing for you to do. So you bring all those things together, and if nothing is happening between 8 o'clock at night in hospital and 8 o'clock in the morning in hospital, then these patients should be offered, you know, the choice of outpatient care, well, same-day emergency care, and being brought back the next day instead of being admitted. We do this all the time, and it does work, and it's you can really stretch the boundaries of same-day emergency care. A CK of 97,000 in a marathon runner, you can do that in same-day emergency care. Very jaundiced people who haven't got biliary sepsis, you can manage them through primary care. New diagnosis brain tumour can go through same-day emergency care. So it's an expanding and very exciting area. What we do hope, though, is that we are looking at pulling down the number of admissions and reducing patients ever having to come to the emergency department in the first place. So making it very easy pathways for the patient you've just seen in clinic who the wheels are just about to fall off and they're clearly coming to the emergency department in the next 2 or 3 days if we don't do something now. And they can all go into the same day emergency care stream, you know, dealing with very complex patients on very complex pathways. Rather than just doing the standard, you know, diagnostic workup of what can actually turn out to be very mild disease.
Yeah, I'm mindful that, you know, that some places, some SDEC facilities are well developed, and others are just getting going, and some aren't even there yet. And so, from your perspective, you know, what are the key elements that you feel need to be in place from an SDEC to be able to support either direct admission or supporting flows from ED?
The more senior you have of decision making in terms of running the unit and accepting referrals and discharging patients, the better. You've got to have absolutely good diagnostic streams, which should be very similar to ED streams. I mean, we use our any CT, we use the ED scanners, and we use them in the same time frame as ED would use them. So, and a lot of administration in terms of planning for patients to come when they really need to come, rather than sit around for 8 hours waiting for an ultrasound that doesn't end up happening that day. So, you know, booking the ultrasound, getting them up to ultrasound, coming to the SDEC facility after the ultrasound, all these things are really important ways of managing your resource. But I would like to hear from some of the people on the call about their questions in terms of what they think is working well for them and not.
Yeah, so anybody on the call, if anyone wants to chip in and ask Dan and Steve any questions or challenge back, and pop your hands up, and I'll come to you as they come in. It's important that, you know, we get a balanced view from across the group as well. So any thoughts would be welcome. So please do put your hands up if you've got some questions, or pop them in the chat, and I'll pick them up from that route as well. Just while people are sort of mulling over those thoughts, Dan, I'm just thinking about, you know, where resources are tight at the moment, and even tighter at the moment in terms of staffing, and what's the best use of consultant time in ED? Where do you think consultant time can add the most value?
Yeah, thanks, Nick. I think that's really dependent upon the emergency department and the underlying staffing model that they have. Clearly, we've got some of the bigger departments in the country who have 4 or 5 consultants clinical at any one time, and they would have someone doing the helicopter epic kind of overview role. They'll have someone doing the pit stop rapid assessment ambulance handover element. You'll have patients in the lower acuity fit to sit area, you know, and that be managed by a consultant as well. So if you've got that ability and that resource, then I think to have a consultant or a senior middle grade managing and looking after each area is really important for decision making, for education and training, for you know, giving patients the best quality of care. And for my default is, what would you want if this is your relative coming into ED? What would you want them to happen? And so the 2 fundamental principles from me would be, you must have an epic, an overarching consultant who manages the department, and the rest of our senior input should be focused on 2 areas. 1, seeing undifferentiated patients as early as we can in the patient journey, and picking out those who are at highest risk of deterioration, whether that's ambulance handover, or some departments that's right at the front door when patients first arrive unheralded. And then the other group is, what can we do to support the bit we're talking about today? So appropriate admission and appropriate discharge and follow up in SDEC or the community. But I think the question depends on the underlying level of staffing for each ED.
Okay, great, thanks, Dan. We've got a question from the group. Sarah Garrett, do you want to just say?
Hi, Sarah Garrett. I'm a commissioner from Warrington CCG. I think it's an interesting debate about the timing of the decision along the pathway of admit or not, and I think because we have almost three decision points, don't we? We have, yes, you're coming into an inpatient bed. Yes, you're coming in, but you're going to be treated today. Or no, you're not coming in, and actually community services can probably manage you really well, therefore go home with something else in the community. And I just wonder about that timeline, and have we got that right? Because if we are making I don't know whether we are or whether we aren't, but if we are making a decision to admit first, without going through can we get you home with community services? Okay, maybe not. Can we then maybe get you in and treat you today rather than keep you overnight? Or maybe not. You know, I guess it's the leapfrog of that decision, because if we admit first, then we've not thought about the first 2. And I don't know whether that's something to be thought through, or what you think, or but I find that an interesting conundrum about how the timing of that.
Steve, do you want to pick that one up? You got your hand up?
Yeah, I think that's absolutely true. I would say that it's not impossible to do, certainly, but it does need a very senior clinical decision maker right at the front, having the initial clinical conversation with the referrer, whoever the referrer is, who can provide enough detail to make that decision. I'm on the phone today, and will be on the phone all day. I'm taking referrals from the community to medicine across 2 hospitals, and instead of just using a DOS, what I know is the capacity of the system at this point in time. So I know what's available, and I know what's available today, and I know what's available tomorrow. So I can put triage, if you like, all those patients into a stream across 2 sites based on the capacity that they currently have. I think it could even become bigger than that you could actually have that kind of clinical decision making done cross trust. But that might be a step too far in the current environments. But you can, with appropriate clinician to clinician conversation, identify those that are definitely going to need admission today, because there is no other way of managing them. Every patient that I send, so 70% of what the calls I get today will be triaged to same day emergency care today or same day emergency care tomorrow. And that works really well. And I think you should always start off with, if you're erring, then you should have patients being admitted from your same day emergency care unit, and your same day emergency care unit should have a pathway that can manage a deteriorating patient. And as long as you've got them in place, I would always start off with same day emergency care and never inflict a patient on the trolley based unscheduled care pathways, which are completely at risk at the moment, and certainly do not help the patient.
Yeah, great. Thanks, Steve. There's a really important question in the chat as well from Azim. Azim asks, we're in the process of developing our SDEC, stroke medical SDEC. Do we need pathways to refer patients to SDEC from ED stroke GPs, or just simple exclusion criteria?
I would absolutely go with just the exclusion criteria, and you will generate that exclusion criteria will reduce over time, but know exactly what you wouldn't be able to manage. But don't say, oh, you know, someone once a long time ago, you know, who pregnant had a seizure on an area, and that makes us really anxious about seeing people who are pregnant or whatever. You know, you just have to, you know, same day emergency care units should have facilities for providing immediate resuscitation and care and get them out. So we locally have a agreement with we're almost adjacent to the ED, and if we've got a really sick patient, then we have access to resus, and that's a given, but we'll take anything else. So I would steer clear of pathways and go for use the criteria to admit tool. If they don't fit that, use SDEC as default, and work on the level of supervision and delivery of care that you have on your SDEC, i.e. you've got a consultant who can manage acute medical conditions and high-risk patients.
Dan, have you got anything to add to that?
No, I think, you know, I'd absolutely echo what Steve said about, you know, this is kind of process, you know, pathways were, you know, 2011, 12, 13, when it first came in, it was pathway based, but definitely the you know, when we pick out the exemplar same day emergency care settings, that's almost always a process, and it's a culture, isn't it? And a SDEC first, and that pervades wherever the patients are being managed.
Just picking up on the SDEC first thing there about what's your thoughts, and I'll go to Steve as well in a minute, what's your thoughts on the sort of positives and negatives around that direct access to SDEC streaming from 111 or paramedics or primary care? What's your thoughts around that?
So yeah, I think that comes down to what's the value added for the patient. Again, it comes back to what's the right thing to do for the patient, and the default again is what would you do if this was your son, your brother, your sister. And where I think direct to SDEC is incredibly useful is to avoid duplication of work, so getting the patient to the right place with the right clinicians first time. But we also shouldn't be streaming everybody to same day emergency care if we can manage within the ED. So that needs an open, honest discussion between ED clinical teams and the acute medical or the same day emergency care teams with what are the cohorts of patients that we believe should be managed in each different setting. And the trusts who've really got that right have had those open, honest discussions. They've agreed on the kind of underlying principles for what's right for patients, and then they'll go with it. And if it's Steve's approach, which is, in my view, the right one, then there's a risk, you know, there's a risk of sharing risk across the patient journey, and providing we're aware of that, then that's fine. That's what we're here to give the best care we can and minimise risk, but it will never be no risk.
Yeah, sure. And I think it is. You know, I know you talked a lot about this before, about how we manage that risk, how we balance that risk, and where the risk actually sits. And as you know, we've said before, risk sits with the patient, and you know, it's as you said, the right decision for them. There's a bit of a chat going on in the chat room around admission rate from SDEC. Steve, do you just want to pick up on that? And I know she put a couple of percentages in there, and
okay.
So
we run a combined SDEC on the county site in Brighton, which has very different admission rates depending on the specialties involved. Basically, all surgical specialties use the unit, excluding gynae, and medicine uses it for all ages. We have a separate service for rapid access for the older patient, but that kind of dovetails in and works out of the same environment. So anyone can go there. Interestingly, things like vascular have a very high admission rate. So there'd be something like an 80% admission rate. Diabetic foots, for example, they do need to come in, they do need to have assessment, they do need to have venous workups, arterial workups, etc. But they can sit in a chair. So why would you have them lying on a trolley in your emergency department waiting for admission? There's no need for that. So we just try and flag them up early, get them round, because we can manage them in a chair before their admission. Surgery runs at about 20%, medicine runs about 10%. And the key is that if you're running a service which isn't 24/7 because you're trying to protect beds, or you just don't have the staffing, or you don't actually need the requirement overnight for an SDEC service, and it sits out of your assessment unit, then you've got to factor in getting your nurses home on time, and therefore you've got to work out on the priority of patients on SDEC and what you're going to do with them if the bed's not ready and your unit is closing. And that's a kind of local agreements, whether they go back into ED streams or whether they board on a ward waiting the bed, and they're all things that have to be considered.
Yeah, that's a key point. Reminder for anybody who's just joined the session, this is an open floor discussion, so please, if you've got questions for Dan or Steve, please put your questions in the chat box or put your hand up and you can ask them direct. Got a question from Muzz. From BHRUT. He's asked, when you developed your SDEC, did you amalgamate the pathways, e.g. dot and pull services? Did you put in the aid criteria or put or not overlap in frailty? Muzz, did you want to jump on and just ask that question directly?
Hi, sorry, it's Mr. Sain. So at BHRUT, we've got a lot of services that overlap. So, for example, there's a ED DVT pathway, there's a GP DVT pathway, there's an ambulatory DVT pathway, and plus there's loads of services that overlap in terms of frailty. So you've got to, you know, some of them will be able to come through us, but the frailty service being developed. How did you able to segregate all of this? Because one of the things I've noticed is that there's a lot of waste in the system, and that causes confusion. And when there's confusion, it's not good for our GP partners, but also not good for the patient. So how did you amalgamate all the services? And the second question I have is, how did you engage the speciality? Because one of the biggest challenges we have at BHRUT is we have to have a post-take for the patient by an acute medical consultant before they go on to the specialty ward, which then has a knock-on effect on ED waiting times, MAD waiting times. How did you tackle that piece?
Okay, I can work through that. Take the first question. The key is to identify all the pathways and find the value in them and remove anything that's duplicating. I think it's an ongoing thing, particularly if we just take the one thing is what is ED expected to do and what what SDEC is expected to do. And I think that there is going to be some dynamics in that, and there's some variation in the system. But at the end of the day, one of our common goals is ED is there to make sure that it's something that can be identified as being managed by a specific specialty, and it's reached the threshold for whatever you agree locally as being managed by the specialty on SDEC. One of the classical things for us would be, we have agreed that no patient should have a CTPA in the emergency department unless it's for an unstable patient or a patient who clearly needs to be admitted because of their type 1 respiratory failure or whatever. Everyone else, if ED needs to decide that it cannot exclude a PE, but has excluded everything else, and at that point, the referral can happen to SDEC, we will see the patient and we'll get the CTPA done if necessary. So it's almost, you know, in that setting, and, you know, some ED consultants might, you know, say, well, I'm quite capable of managing a PE and discharging a patient, but that's not the point. Of course, we know that you are capable of doing that, but that patient is clogging up your department, and potentially wasting resources in an area and using a trolley when we would be very comfortable to manage this patient without a trolley. So all those things have to be discussed. DVT, for example, we've removed that all into community. So community refers straight into ultrasound. And if the ultrasound's positive, then they come to SDEC. If ED identifies someone walked off the street with swelling, if they think that it is a DVT and they need a scan, then they can refer them round at the point that they make that identification that a DVT needs to be excluded. So it's about using SDEC when SDEC works for you, in terms of it's taking the pressure off the other areas. The second point, in terms of does everyone need to be seen by an acute physician before they go to a specialty ward? Well, that is ideal. And the question is why is it a problem in your trust, or you identify as a problem in the trust? Because we would always identify those ED patients first to see, and and our highest discharge rates are in the patients who are still in ED. Overnight, if somebody is identified at a registrar level as needing admission, then they can go to the wards appropriately overnight. So during the day, everyone gets seen when they are suitable for a acute medical review. So it's not technically a ward round, it's a constant ward round of everyone on the acute floor, and there's no issues with access to acute medicine.
Thanks, Steve.
Thank you.
Was that all right, Muzz?
Yes, perfect. Thank you.
Thank you. Just thinking about that transfer of patient, that transfer referral essentially from ED to SDEC, or anyway really. Dan, sorry.
Well, anything's fine. I don't mind what I'm called. Just thank God you got rid of that photo.
Yeah, get rid of the photo. What's your thoughts? So, do you think all referrals from ED should they go through emergency medicine consultants? What grade, what level are we talking about in terms of those referrals out?
Yeah, so at the risk of kind of repetition from my point of view, it again comes down to what would you want of your relative, and most of us would say that while there is a consultant rostered on the shop floor, then we would want our relative to at least be discussed, if not be seen by a consultant. So there's certainly been a move the last few years for all patients requiring admission to be, or potentially for admission to be discussed or reviewed by a consultant. That's not universal by any means, but it's certainly much more common than it was a few years ago. Clearly very tricky out of hours and overnight for those EDs that don't have 24/7 consultant coverage. The evidence is the evidence I've seen is roughly a 3 to 5% reduction in admissions if that process comes in. That was evidence prior to criteria to admit. So that's a kind of ballpark figure, but it's pretty resource heavy, and so how you delegate You know, what you don't want to do is have 10 juniors queuing round the corner to discuss with the consultants. You've got to make sure it's as lean as it can be and as effective approach as it can be.
Steve, do you want to come back on that?
Yeah, so I mean, it is during the day. I think the ideal thing is you know, some will be discussed with ED, some will be discussed with acute medicine or a specialty, and you know, what we try and steer clear of is in our specialties is you can't talk to me. How it used to be is a bit like Clint Eastwood with his gun and Dirty Harry saying, "Are you feeling lucky, punk?" In terms of, am I going to accept that referral? We get rid of that, and we basically, if anyone says, "I'd like to refer you a patient," I correct them and say, "Let's discuss the patient and let's work out what would be best for the patient and how we're going to add value." So it's not, you know, our GPs do it all the time now. They're not referring for admission, they're referring for assessment or just referring for a discussion. And then we have this negotiation of, oh, well, if that's all they need, I can still do that. Or, well, it makes sense that they come up to see me today because they need an X-ray and they're going to need bloods, and logistically it's really difficult for you to do that, particularly on a Friday, for example. And so it's just a discussion, it's an open discussion. Out of hours from ED, what we found is that to get into SDEC didn't work out of hours if you put a referral into the specialty, because by the time the medical registrar has got round to actually evaluate the patient, it's probably 4 o'clock in the morning. Everyone's gone, hey, you might as well stay until the post-take ward rounds. So we actually move that to an electronic referral saying if ED are happy to send the patient home, but they have identified that this patient needs to be seen within the next 24 hours, discuss it at a middle grade level within your ED or whatever you're comfortable with, put in the referral form, we will contact the patient in the morning and we will see them the next day. And that means that we get a lot more discharges from ED overnight rather than stacking up for the morning ward rounds. And that's something that we learned over, you know, about 12 months, that it was it didn't make any sense to keep these patients holding in ED for a post-take ward round.
I suppose that goes back to your point before about, you know, having exclusion criteria rather than just pathways, because then it lends itself to more of a conversation that takes place. And those exclusion criteria may
and
be.
We do see some, you know, different things from ED, but you know, as long as you've got a referral, all the referrals come through from that junior and also the consultant who's responsible, ED, and so that we can channel back any feedback like, you know, hey guys, this was musculoskeletal back pain, there is an MSK pathway, you didn't need us, you know, or whatever. But the key is that if someone asks for your help, you provide that help, and you have to have a reasonable one-way valve referral process, that it can be fire and forget. And, you know, you can't say, well, you did a rubbish referral, therefore we're not going to see the patient, when that's what, you know, the priority was getting the patient out of the ED at 2 o'clock in the morning. And so we are very sensitive to the need for that, and therefore what we will see from ED might be lower threshold than, you know, during the day. But that's absolutely okay, and we just work that into the system.
Cool. Question from David in the audience.
Yeah, thanks very much. I'm David from East Kent Hospitals. I think you might have just answered the question as it was forming in my mind. With a service has a limited amount of clinicians and resources, targeting your SDEC opening hours to get the biggest bang for your buck is obviously important. So to open too early when the swell of patients happens in the back end of the day and early evening. The question was around whether we should move those resources and open at 12 to 12, or whether the daytime was the best time to deploy those limited resources with the normal distribution curve of attendances. But I think your answer just there around seeing patients in the evening and having the confidence to refer them back into the SDEC might be a solution to that. But I don't know, have you got a view around whether it's a 9 o'clock opening or a 12 o'clock opening and stretch it into the evening would give you the better bang for your buck?
I think that's how you can manage your workflow, and evening working is always a challenge. So what we do is we try and flatten that curve of evening work, and totally I appreciate that acute medical work, apart from the post-take ward round, doesn't happen in the morning. So what we do, if I take a referral today and it's beyond 2 o'clock, I'm thinking, what's the point of me seeing this patient today? I could see them tomorrow. And so we actually stack up a lot of patients for next day early morning review. So they're coming up in the mornings rather than necessarily coming up in the evenings, depending on the need from primary care. A lot of the problems that you see, you know, they've been having symptoms for weeks, and the difference between having symptoms for weeks and identifying a possible problem and the chance that something, you know, some stable symptom is going to deteriorate between now and tomorrow morning is incredibly unlikely, as long as you've worked through that you don't think that this is a vascular event. So that's basically through history alone you can work those ones out. So we tend to stack things for the next day and keep ourselves busy, and so in fact we run out of patients to see by probably 5 o'clock in the evening, and that's just a dribble from ED. And like we say, we'd continue with that process. It was 3 o'clock in the afternoon in ED. We say, well, why don't you do X, Y, and Z right now? Ping these bloods off, send the patient home, bring them back tomorrow.
And that leads nicely onto a question from Sarah. David, was that okay? Does that answer your question?
Yeah, that's very helpful. I think we've got a couple of nuggets for us to digest and work on. Thank you.
So Sarah was asked in the chat box about patients going home overnight from ED. Does SDEC call them and decide virtually to bring them back, or does ED just say just bring them, just turn it back?
No. You've got to put as much logistics in the system that you can. Some of those patients will need scans. Some of those patients, the expectation would be that ED had put in the request form for the scan, and we will liaise with the patient based on the time of their scan. Ultrasound scans are generally the ones that cause most trouble. What our units are fundamentally run by the nursing teams and the admin teams. The only reason clinicians are there is because that's where the patients come to. So it's almost like it's the default thing is that doctors like working in these areas because there's more office space. It's not, you know, there's not other demands. Generally, they do have daylight, and it works for them. But yeah, you can't. The biggest resource we have is in our admin team, and that is purely to streamline logistics and get the most out of the care spaces. For example, if you're dealing emergency transfusions, how many are really emergency? If they're coming through an SDEC, well, it can probably wait till tomorrow. How many units do we give? Well, we give a maximum of 2 units, and you can a maximum delivery of 2 hours per unit. So we know how many transfusions we can do out of a single care space in a day, as long as the patients arrive at the correct times. And that's all planned through admin.
Again, nicely feeding into a question possibly from Azim again about SDEC primarily run by ED senior clinicians or acute medicine, and how do you involve other specialties to review patients in SDEC? Possibility of hot clinics, so bringing patients back to hot clinics.
Well, that all depends on the engagement of your specialties and their resources to provide them. You know, I think SDEC should be open to all specialties, and specialties should be encouraged. And I think that's the value of an acute medic. So, you know, over time, you know, when I first started, you know, if you saw yellow patients and you call the gastroenterologist, so they go, "I'll admit them and I'll see them on tomorrow's ward round." And we went, but he's just yellow. He can eat and drink and he can do everything else. He just happens to be a different colour to you or me. So why can't we can work him up. He can come back tomorrow morning for your ward round and you can see the patient on SDEC. So there's lots of different ways that you can do that. Hot clinics is just part of SDEC, and it's just how proactive your consultants in the specialty are. So some SDECs you wouldn't need to see jaundice, because if a patient is jaundice, they're going to go straight into the gastro-hot clinic. So we shouldn't think of SDEC as simply being what's run out of an SDEC unit. You've just got to identify all the patients that in the traditional model would have been admitted under you that could be managed in another way without requiring a hospital bed, and that can happen within the specialty. I mean, a classic example to us is gastro do not have the space or the capacity to do ascitic drains, so we deal with all the decompensated liver disease ascitic drains. In fact, most of the patients are on a self-referral pathway. They call us when they think that they need a drain, and we bring them in for a drain, rather than them pitching up on a Thursday evening in ED saying, oh, it's getting really uncomfortable now, I want my drain. So and the value to us is I'm not that bothered about gastro not doing it, because ultrasonography and insertion of a ascitic drain is a competency for most of the junior medical team, and that gives them, we train them how to do that. So it swings and roundabouts, but don't think that SDEC is just what's running out of your unit.
Yeah, great. So any other questions? So Dan, I'll come back to any questions. Please, just a reminder, please pose them to Dan and Steve. We're not going to have a separate Q&A session, just mindful we are coming towards the end. There's 15 minutes maximum left, so if you've got any burning questions you want to ask these two guys about anything around the front door, then please take the opportunity while we have them. Dan.
Yeah, it was just I've heard Steve speak before around the Brighton, but never in this sort of detail, and the cultural bit stands out, doesn't it? The bit of how the real drive to, it's a pull model rather than a push model, which is the kind of holy grail for a lot of us that work in less functional kind of organizations and systems, and the cultural element is driven often by clinicians who are just really passionate about it and trying to do the right thing, and that kind of pervades a lot of what Steve's talking about, isn't it? You and the team have driven that, and that's huge credit to you, and I hate bigging you up because that's not what I do, but I think that there's something there that it's how do we translate it into some of our systems who are more challenged and haven't got the cultural element. That's the tricky bit, I think.
Thanks, Dan. I mean, one thing I'll put in that, the bit that holds us back probably at the moment is ED's recognition of what we can do on SDEC. So we get to the point now that we will say, can we see this patient on SDEC, and we might get an ED senior or so that, oh no, I think she's too unwell for it, and it's like, and then you go around and go, just walk round and I'll go and see you around the corner. It's getting it out there that, I mean, ED are very, very good at ruling out the severely critical disease. The downside of that is they think pretty much everyone's got severe critical disease, and everyone goes on a trolley or into a chair, and no one can walk around for an x-ray because they need to be pushed around with a porter, and it's just like, come around this side and we'll make you walk for your chest x-ray and do X, Y, Z. So it's what's really helpful to us is if we're challenged that point of referral, can you see this patient on SDEC, as opposed to I've got a referral for you or whatever, and you're the ones with the eyes in ED who can see the patient then. And what we really want to know is, have you stood the patient up and seen them walk, and did they look like they were about to keel over? And if not, they can come round to SDEC. So that's the bit that's a bit more push. We'd like to see a little bit more push from the EDs.
Yeah, thanks, Steve. And got a question from, hi Adele. Hi Adele, do you want to put your question to Steve and Dan?
Yeah, thanks, Nick. So I'm not a doctor, and I'm a very old-fashioned nurse. And this is fairly new to me, but a question, because we're talking about this from a front door perspective. In the current climate, where we've got loads of people off sick, community services are not up and running as best they could be. Simple thing like can't get a patient out of bed because they need IVs, but there's no community IV service because the staff are off sick. If we talk about Backdoor, what is the role of SDEC in Backdoor? In the delivery of supportive care in a level 4 incident as we are now, or when a trust becomes overwhelmed?
I'm happy to come here. I think SDEC was always, I was always doing the back bit of SDEC when SDEC was all about the front door. And you know, the value of SDEC to me is get people into beds, and you can't get people into beds if you've still got people in beds that could be out of hospital. So to be honest, it's a bit Blue Peter. You know, you identify something, you know, so the classical one, as you say, is someone's waiting IVs in OPAT. And so what we do is we kind of own the OPAT service. So if it's not available at point of discharge, in fact, we work so closely with OPAT, the OPAT referral will go in and OPAT will say, we haven't got any capacity, but we will on Monday. Can you hold the patient until Monday? And so if the patient needs to come back for 3 days for IVs via SDEC, we accommodate. You know, it's about, it's having this level of flexibility and just wanting to help. Another example we had is heme-oncology was being bedded out, so they couldn't get their blood transfusions and their plate infusions, but fundamentally they were helping us by us having more beds in the system. So at that point we just said, well, that makes sense. So if you haven't got capacity via platelet transfusions, we'll do them until we free up your heme day case unit, so without beds in it, so that you can get back on track. You know, it's about just having that flexibility. And so there's nothing that you can't do. You know, the other thing that I think is useful to start off with for another, number one is it's got to be open every day. There has to be confidence and trust that someone can send someone home and they will get the follow-up, not, oh, I'm sorry, we're closed, we haven't got this. Because as soon as you refer to a service that can't accommodate, that's the last time I'll ever call that service, because it's just a waste of my time. And we recognise that. We have to make referrals very easy for people, and, you know, just pick up the pieces if that's it, because everybody's stressed. And then if there was a lot of problems, then we'll feedback to service and just say, we could have done this better if we had this information, or if this referral. So it's a constant dynamic process of changing the way processes are happening under the current environment. Yeah, so I think everything can be, using it as a crutch is entirely reasonable when you're first starting the service. You know, anxious patient going home, doesn't really want to go home, but we all know is just going to do well, they're recovering from their chest infection, etc. Tell them that they can come back in 2 days to EACU, and we'll look over them and see them. It's freed up another bed, and it's, you know, and then over time you'll realise, well, maybe there's other ways of managing that. But SDEC is in its greatest value in providing backdoor care when there is no other way of providing it. And what we realise is that to get anything done by primary care within 2 weeks of discharge is incredibly difficult now. And so we will accept anything that's outstanding up to 2 weeks post-discharge. But what we're learning now is, in fact, a lot of these things could have actually been done virtually. So instead of them coming back to have their bloods done in a week to see whether they can start their medication, we, you know, encouraging, maybe you should, on your wards, you should have 5 virtual beds. So you can send that patient home, give them a phlebotomy form, they go and get their bloods checked on the ward round. You can then go, oh, he was due to have his bloods done today, let's check them. Oh, they're fine. I'm going to communicate with the patient. And therefore, the same team is owning the ownership of that post-discharge, rather than we did a bit and we didn't really know what was going on, so we've discharged them to SDEC and then we've got to start again. So it's, you know, it develops. There's an organic development over time, depending on what you actually find you're getting in your SDEC. You go, you know, there is a time when you go 20% of the patients that we see are pretty sure that, you know, a medical registrar tap on my door, say, why do we see all these patients? We're not adding any value. And we go, OK, let's come up with a new pathway then. Yeah.
Thanks, Steve. Adele, does that answer the question?
Could we clone Steve and deposit him in various organisations across the country? That would be fab.
We'll try. So
I have lots of bad points as well. Okay, be careful.
We'll try and manage those, or maybe we'll just take it temporarily.
So one last question I'm going to put, and then anybody else, please feel free to chip in. I'm going to go to Dan first, and it's a topical kind of time of year question. What was on your ED and SDEC Christmas wish list? And then second part of the question, what's your New Year's resolution for how we can do things better within ED and SDEC? And then I'll put the same question to Steve as well.
Yeah, I probably should have. I didn't really think about a Christmas wish list. I think at Lincoln we've had huge issues for a long time around recruitment and retention of staff, and after the last couple of years we've worked really hard on getting our staffing right. And for me, the big focus this year is on capacity and demand, and getting from an ED point of view, evidence basing our rotas to meet demand. And we're absolutely getting there. We've recruited 40 members of staff in ED with either membership or fellowship. We've got rotas now that are evidence-based. We've gone from 3 substantive consultants up to 24 consultants across our 2 EDs. So we've done a lot around recruitment, retention and capacity and demand. And the reason I mentioned that wasn't to big up what we've done, but it's an offer there that we've, you know, within ECIST, we do a lot of work on capacity and demand within EDs, and that work is now moving into same-day emergency care, into acute medicine. And very happy, myself and Chris Green from ECIST and others would be really happy to support any EDs, or even for, you know, SDEC or acute medicine, to look at how can we evidence-base your rotas, look at what demand is coming in hour by hour, day by day, and actually just model the gap and show where the gap is, where you're not meeting your demand, and then help and support from a recruitment and retention point of view. So that offer's there for anyone that would find that useful.
I'm going to go to Muzz before I go to Steve.
Hi Nick, yeah, so I actually totally agree with what Dan has just said, and actually it's going to be good learning for the ED juniors as well, and to be able to work collaboratively with the ED floor. So if you can share that'd be really helpful, because one of the things we find is there's a lot of duplication of work. We had a very good ED assessment, and actually a medical clerk doesn't add much value to it. Why don't we just use the ED clerking and actually support the decision making? And it's good for the ED juniors, and it also reduces the pressure on medicine, but I'm not quite sure how to crack that egg.
Thanks, Muzz. I'll go back to Steve then. So Steve.
Well, we cracked that in terms of single clerking. So our ED SHOs, if they see someone that they ends up as a referral, they are clerking the patient to the same level as what would be needed for an admission. So when the patient, if they do send someone home from ED without something simple like query DVT, which, you know, will be done probably electronically, documentation. But if there's a patient who has been seen in Major's area and they've been clerked and it's been discussed with the registrar or the consultant on night, and it's kind of like, yeah, we can see that there's some problems here, and we've identified, you know, some liver dysfunction, and we're not really quite sure what's going on, but they seem very stable. Then they get discharged with the referral for SDEC, and we get their notes. So when they arrive on the unit, we've got their clerk notes, and basically we just make a registrar level or consultant level decision on how we move forward. So yeah, we would consider our ED juniors to be clerking doctors.
Dan, just picking up on one of the last questions, the last question before we come to draw this session to a close. Top tips for you in terms of managing demand at the front door, not specifically around SDEC, but just around that management at the front door?
Yeah, I mean the one element that we probably haven't covered and won't have time for now is that we've quite rightly focused on the admission avoidance, which is that's the big area to discuss. I think there's definitely something about attendance avoidance. Some of that's been through the work of 111, but there's definitely some other things we can do to avoid attendances, so patients who don't come to an acute trust at all. Steve does a lot of that through SDEC and through the GP phone calls. But when you look at the GIRF data, for example, for the variation between systems of the proportion of patients who attend ED each year, it's astonishing. You've got some trusts who've got 45% of the catchment population attending ED each year, and you've got other trusts who've got 13, 14, 15%. And I think a big focus for me in the next sort of 3-6 months is what are those systems with the really low proportion? What are they doing differently? How's the primary care set up? What are they doing differently to manage it? And then what can we learn and share? So that's, I think, a big piece of work kind of moving forward with regard to attendance rather than admission avoidance.
Excellent. Guys, thank you so much for your time today. I'm mindful of the time. We're just coming up towards 12 o'clock now. Just want to thank Steve and Dan again for your time. I hope everybody has found that helpful. As I said, the recording will be available on our YouTube channel in the next few hours. We'll circulate it around to the members on this group, and you can share it with your team. Steve, did you just want to come in? You're on mute. Steve, you're on mute.
My last nugget, the biggest thing that I think has worked for us is to leave the clinician out of the process when at all possible, i.e. the nurses are running the unit in terms of making sure that the exclusion criteria are adhered to, accepting everything else, and their links with their colleagues across the entire trust. So that's what opens the OPAT pathways, because they're nurse delivered, and so you've got nurses talking to nurses, trying to deliver the best outcome for the patients using the minimum amount of resource. And I think sometimes us clinicians can get overly we might silo work a bit, and sometimes we think we have our own little kingdom and it's not available to other people. But the whole point is you've got a limited hospital estate, you've got a lot of patients that you've got to get through it, and we've got to just make sure that this can happen. And nurses unlock pathways a lot of the time. Thanks, Steve. That's great. So thanks for your time again. Just a reminder, our next webinar, Crystal's put it in the chat for you. We will circulate it around after as well. We don't want to put their email addresses in the chat now. Crystal will make sure that lands in your inbox. That's on clinical decision making for early discharge. So ensuring that clinical decision making to ensure that early discharge for patients. There is a feedback. We're always looking to improve what we do. There's a feedback form there. It'll sit in your chat after this webinar, so please do take the moment to fill that out for us. That just helps us improve what we already do and inform how we can put on different or better webinars in the future. So, but for now, I'd just like to thank everybody for joining us today, and again thanks to Steve and Dan for taking the time out of their busy schedule to come and join. So thanks a lot, everybody. Have a good rest of the afternoon.
Thanks, Nick.